Neurology quiz number 124. Describe the clinical features, pathophysiology, investigation and treatment of transient global amnesia or TGA. TGA is a clinical syndrome characterized by sudden onset of anterograde amnesia or inability to encode new memories. It also includes repetitive questioning. There may be a retrograde amnesia component. It lasts up to 24 hours. Other neurological functions are not impaired. Relevant anatomy. The Papez circuit shown here is crucial for short-term memory. The hippocampus on each side projects via the fornix to the mammillary bodies, as shown in red, and subsequently to the anterior nucleus of the thalamus, as shown in green. From here it projects to the cingulate gyrus of the frontal lobe and back to the hippocampus, as shown in blue. Involvement of the hippocampus will produce anterograde amnesia. The CA1 sector or Sommer's sector in Amon's horn of the hippocampus is especially susceptible to ischemia and metabolic stress. This figure is a coronal section of the hippocampus showing the CA1 sector or Sommer's sector in Amon's horn, which is especially susceptible to ischemia and metabolic stress. Clinical features. Typically, TGA is encountered in patients aged 50 to 70 years. It is more common in people with migraine and sleep apnea. Patients are noticed to have acutely lost the ability to comprehend their situation and surroundings. Patients repeatedly ask questions such as, "Why am I here? What time is it? How did I get here?" also known as the broken record phenomenon. Answers to their questions are immediately forgotten owing to the patient's inability to encode new information. Retrograde amnesia or recall of information learned before the onset of the episode is common, but is more variable and can extend back to hours or days. Immediate recall. For example, the digit span is intact as it is not mediated by the Papez circuit. During an episode, patients are not aware of their impairment and therefore may be labeled as confused or delirious. Alertness, personal identity, recognition of family members, speech, and motor, sensory, and coordination functions are all preserved. Episodes may be preceded by a precipitating event such as activity associated with the Valsalva maneuver, emotional stress, immersion in cold or hot water, sexual intercourse, or pain. The memory disturbance typically lasts a few hours, usually 4 to 6 hours, and always less than 24 hours. Subsequently, the patient progressively recovers the ability to register and store new memories. A residual memory gap for the duration of the episode is common. Diagnostic criteria for TGA, as proposed by Hodges and Warlow, are as follows: a witnessed attack with clear-cut anterograde amnesia and no other cognitive deficit, no loss of personal identity or clouding of consciousness, no accompanying focal neurological symptoms, no recent head injury or seizures, and resolution within 24 hours. The differential diagnosis includes focal seizures, including transient epileptic amnesia, post-ictal state, stroke/TIA in the posterior circulation, post-traumatic amnesia, metabolic disorders such as hypoglycemia, and dissociative disorders or psychogenic amnesia. Pathogenesis. There is no consensus regarding a common underlying pathogenesis of TGA. Hypotheses include venous congestion. The leading hypothesis is that TGA is caused by abnormal cerebral venous drainage from the temporal lobes. Precipitating events associated with the Valsalva maneuver decrease venous return and cause retrograde jugular venous flow in the presence of jugular vein valve incompetence. Resulting venous hypertension in the medial temporal lobes could explain memory impairment. Studies have shown that patients with TGA have jugular vein valvular incompetence more than controls. However, this does not explain why the venous hypertension would selectively affect the medial temporal lobes and why the memory loss would persist beyond the short period of venous hypertension. This figure demonstrates the venous hypothesis. Increased intrathoracic pressure caused by a Valsalva maneuver would cause retrograde venous flow in patients with valve incompetence in the internal jugular veins. The resulting venous congestion would preferentially affect the medial temporal lobes, causing anterograde amnesia. Blood from the temporal lobes is drained by the basal veins of Rosenthal and the internal cerebral veins, which in turn drain into the vein of Galen and from there to the straight sinus, transverse sinuses, sigmoid sinuses, and finally into the internal jugular vein. Another hypothesis is arterial ischemia. This is mostly supported by DWI changes on MRI. However, these changes are inconsistently present, reversible with time, and do not respect a clear arterial territory. Ischemic symptoms lasting as long as most TGA episodes are commonly associated with permanent lesions on MRI, which is not the case in most patients with TGA. And number 3 is migrainous phenomenon. TGA has been hypothesized to share pathophysiologic mechanisms with migraine. Some studies show that patients with migraine, particularly middle-aged women, are more prone to experience TGA. It has been proposed that cortical spreading depression could explain both conditions, in the case of TGA by altering CA1 neuron excitability. Another hypothesis is epileptic phenomenon. Focal seizures arising from the mesial temporal lobe can mimic episodes of TGA. However, no EEG abnormalities are noted during and after episodes of TGA. Moreover, the prolonged duration of the amnesia without spread of cerebral dysfunction to other brain areas argues against this theory. Investigations. No investigation can confirm the diagnosis. The diagnosis relies on a detailed clinical history, cognitive evaluation, and physical examination. Testing is ordered to rule out TGA mimics discussed in the differential diagnosis. Brain imaging. CT brain is often performed emergently and is normal. Brain MRI. Many case series report the finding of one or more punctate lesions. Mean lesion size 4 millimeters in the hippocampus on diffusion weighted imaging, with an incidence that ranges from 60 to 90%. These are associated with small reductions in the ADC values and are most often unilateral and left-sided, but right-sided and bilateral lesions are also reported. Peak incidence is between 12 and 72 hours. Lesions often persist for 7 to 10 days and then resolve on follow-up imaging. By contrast, lesions due to ischemic stroke or TIA are always larger, are more likely to be observed in the first few hours of onset of symptoms, and evolve into a permanent T2 abnormality. This slide shows diffusion-weighted MRI from 3 patients with TGA showing tiny areas of diffusion restriction in the hippocampus bilaterally in picture number 1, on the left in picture number 2, and again on the left in picture number 3. EEG. During and after typical TGA episodes, EEG is normal. Transient episodes of amnesia can be caused by seizures arising in the temporal lobes and are called transient epileptic amnesia. However, these tend to be shorter and are recurrent and may be accompanied by other manifestations such as oral automatisms and olfactory or gustatory hallucinations. Management. Patients with TGA should be observed until the episode resolves. Investigations in the acute care setting include brain imaging and EEG. Lab tests to exclude intoxication, infection, and metabolic derangements may be performed. Reassurance of the patient and family that the condition is benign and self-limited is necessary. Prognosis. The clinical course is self-limited and the short-term prognosis is excellent. Memory usually recovers fully within days, but mild residual impairment can occasionally persist for weeks. Reported recurrence rates for TGA vary considerably among different studies, but recurrence is relatively uncommon. Factors associated with recurrence in some studies have included younger age at first episode, female sex, shorter duration episodes, and history of migraine. Most studies report no increased risks of epilepsy, stroke, or dementia, or increased mortality following TGA as compared to age-matched control subjects.